Thanks, Jeff. I hope you can hear me well. It's always nice to talk about this topic, honestly, elevation acute coronary syndromes. There are guidelines. I think that they need a little bit of an update. They were published in 2014 and 2015. There's going to be an upcoming guideline on revascularization that addresses some of the topics of non-ST elevation acute coronary syndromes. So I've been working on those guidelines with the writing committee. So, I think they're coming along very nicely, and also gave me the opportunity to update myself on that topic. But it's interesting that we can see that we've come a long way in the treatment of cardiovascular disease with a significant decline in death over the past 6 to 7 decades. And you can see here that revascularization has taken an important role, and also in the treatment of acute coronary syndromes. Here we have the inception of coronary angioplasty by Gunzig in 1879, then the TIMI-1 trial addressing issues with reperfusion in acute coronary syndromes. Then the demonstrated superiority of primary PCI versus fibrinolysis in acute myocardial infarction, and then other advances with EP, and then in interventional trials that continue to work as continue to evolve as cardiovascular death decline. So this is a little bit of the scope of the problem. So there's about 1.4 million hospital admissions for ACS in 2010. About 45% are of those. I'm sorry, about 3/4 of those are non-ST elevation ACS. So it's a significant problem. And this continues to be the same even in 2020. So how do we classify acute coronary syndromes? We have a whole spectrum here that goes from like the green to the red and hot. So and then in the other end, the counterpoint is stable angina, which is usually demand ischemia, and the pathology is a fixed plaque that is very fibrotic. In non-ST elevation acute coronary syndromes, we usually have a thin fibrous kappa atheroma that ruptured and exposes the lipid core to the bloodstream with formation of a thrombus overlying the endothelium. So patients usually present with EKG changes that can be either ST depressions or flip T waves. And then when there's a complete epicardial coronary occlusion, then we have ST elevation, and that topic was already addressed very well by Michael Dial a couple of weeks ago. So the presentation of unstable angina can be a new onset, crescendo, rest, or recent intervention. We will see in the next slide. And then what differentiates unstable angina from non-STEMI or non-ST elevation acute myocardial infarction is the presence of positive biomarkers without Q waves. So the clinical presentation is usually prolonged angina and chest pain at rest of more than 20 minutes, or new onset angina, class 2 or 3 of the Canadian Cardiovascular Society. Recent destabilization of previously stable angina with at least class 3 characteristics, that's called crescendo angina or post-MI angina. So my presentation is going to be very practical and directed on to the pathway of the care of these patients. So when patients present to the emergency room, they have to be evaluated very thoroughly. Make sure that the patient is breathing, has a blood pressure. They need the observation. You have to look for jugular vein distension to address the issue of right ventricular involvement, listen to the lungs, and auscultate for RALs. More recently, because of the COVID pandemic, we're not touching the patients too much and we're practicing social distance, but it's very important that we examine the patients. We listen to the heart, we listen, we look for murmurs or gallops, especially looking for mechanical complications in patients that come with STEMI, presence or absence of stroke, presence or absence of pulses, and just to make sure that we're not dealing with a differential diagnosis of aortic dissection, presence or absence of systemic hyperperfusion with the skin that can be full and clammy. So the recommendations from the guidelines for early risk stratification is that we need to do an EKG within 10 minutes of hospital arrival at the emergency room in patients with symptoms suggestive of ACS. Now, the symptoms suggestive of ACS can be very deceiving sometimes because elderly patients and females do not present most often with typical angina. They can present with shortness of breath or syncope as well. So we have to be very thorough and careful and suspicious in patients that come to the emergency room with those symptoms. Then performing serial EKGs is also helpful to catch dynamic EKG changes. We have to measure cardiac troponins in all patients with symptoms consistent with ACS. That's a class 1A indication. Serial cardiac troponins 3 to 6 hours after symptom onset is also useful. Using risk scores, and we will talk about those, either the GRACE score or the premium risk score are well backed by evidence, and then can be very useful in stratify the risk of the patient and also tailor a more aggressive or more conservative management. In patients that have non-diagnostic EKG or have ST depressions in V1 to V3, that's usually posterior epicardial ischemia. So V7 to V9 may be useful. In patients with ST, so I'm sorry, I'm going outside of my boundaries, but this is important to highlight. We had a patient, an early patient a couple of days ago that came with ST elevation in inferior leads, and I asked about the JVD, about the pulmonary fields, and then I asked, well, where are the right-sided leads EKG? Well, it was not done. So B4R has high sensitivity and specificity for the diagnosis of RV infarct, which is an important diagnosis because it affects prognosis. And then continuous monitoring with 12-lead EKG may be a reasonable alternative to initial non-diagnostic EKG in patients with intermediate high risk for ACS. And then a pro-BNP may be considered to assess risk in patients with suspected ACS. So this is an old study. I see that Steve Borzak is logged on this lecture, so he did lots of research back in the 90s. I'm sure he's continued to do research, but he's probably very familiar with this data. This is data from the GASO 2B trial. This was a 12,000 patient study that included patients with STEMI and non-STEMI. So it allowed the assessment of the whole spectrum of patients with acute coronary syndromes. And you can see here the initial presentation, the initial EKG determines prognosis. So patients that have only T wave changes usually have the best prognosis. Patients with ST elevation only usually have increased mortality within the first 30 days, but then their events tend to stabilize over time. And then patients that present with ST depression don't have as many events in the beginning, in the first 30 days, but events continue to occur. And that's because the population of patients that present with ST depressions or non-STEMIs are usually older. They have a more burden of coronary disease, and they're more likely to have a recurrent event. So it's very important not only to treat these patients in the acute upfront phase of their disease, but also treat these patients and use very aggressive secondary prevention measures. Cardiac troponins are the preferred biomarkers, either I or T, whatever your hospital uses is fine. Has high myocardial tissue specificity and high clinical sensitivity. The detection of a rise and fall in the measurements is essential to the diagnosis of MI, And it's important to distinguish acute causes of troponin elevation from chronic elevations that don't tend to change acutely. And these are pictures from the most recent fourth universal definition of myocardial infarction. And I think it's nice to illustrate because this is a dilemma that we're faced with in clinical rounds all the time. So first of all, when we see a patient, and we are consulted for to see patients with elevated cardiac troponins. So what we're looking to diagnose myocardial infarction is a troponin rise followed by a fall. So versus the, the, the stable troponin levels that is usually associated with chronic myocardial injury that you can see, for example, in structural heart disease, in patients with dilated cardiomyopathies, in patients that don't clear the troponin well, for example, chronic kidney disease. Then the troponin rise and fall you can see with acute ischemia, and that's actually acute myocardial infarction. That could be type 1 MI with atherosclerosis and thrombosis, like you can see in this part of the slide, or it could be an imbalance between oxygen supply and demand, and that can be caused by severe hypertension, arrhythmias, vasospasm, spontaneous coronary artery dissection, or patients that have a supply-demand imbalance alone, for example, patients with severe hypertensive crisis. And now you can have also acute myocardial injury in cases with acute heart failure or myocarditis. And then these are the most frequent cases of direct myocardial damage that causes troponin elevation. So the systemics that we have to look for is pulmonary embolism, toxicity by chemotherapeutic agents, trauma, renal failure, sepsis, strokes, or arachnoid hemorrhage, and now we have the STEMI mimics that come in patients with COVID that we also have to include in our differential diagnosis. So troponins and risk stratifications have been is important. So troponins have been validated in the risk stratification of patients with non-ST-ACS, and you can see that the survival in patients with troponin positive is significantly lower than in patients with negative troponins. These are data from even 1998 from the GASO-2A trial. And then from TIMI-3D, you can see that there's a stepwise increase of the outcome of death with increasing values of troponin I. And also troponins can help us, as we will see later during this lecture, can help us stratify and tailor the treatment. As you can see, that the patients that are troponin negative are less likely to derive a benefit from an invasive therapy as compared to patients who are troponin positive that are significantly more likely to benefit from an early invasive therapy. These are all data from the Tactics TIMI 18 trial published about 20 years ago. So what do the guidelines say? With contemporary troponin assays, creatine kinase CKMB or myoglobin are not useful in diagnosis of ACS with a class of recommendation of 3 with no benefit and level of evidence A. So no need to get other enzymes. Some people have looked at this as a waste of resources, so troponins are sufficient. What I'd like to see, however, is when we admit patients with acute coronary syndromes, I'd like to see serial troponins to analyze the curve and see that there's a rise and a fall. Then how do we put all these together? We put this together in the clinical evaluations and the biomarkers in the clinical scores. So this is a TIMI risk score that has already 20 years, and we're still using it because it's so simple. So it includes 7 variables. Those are age more than 65, 3 or more cardiovascular risk factors, non-coronary artery disease, ST deviation, angina within the last 24 hours, aspirin within the prior 7 days. That means that the patient is developing symptoms and regardless of the presence of an antiplatelet, and elevated cardiac markers. And then the, the, the patients can be stratified as low risk in those with TIMI 1 or 2, TIMI 0, 1 or 2, moderate risk with a TIMI risk scores of 3 and 4, and then high risk when the TIMI risk score is 5 or more. And you can see that there's an increase in events with the increasing TIMI risk values. The other, and then you can easily use your phone, go into the TIMI study group webpage, or you can, I think that they still have an app, and the ACC has apps that you can use to estimate. But you know, these are easy to memorize. This is just so simple. I always use it to make decisions on rounds. The other risk score, which is a little bit more comprehensive, has a C index of 0.81. So that's the predictive ability of the model, of the multivariable model. Remember, the C index of 1 is perfect prediction, and a C index of 0.5 is like tossing a coin. The interesting thing is that the TIMI risk score has an index, a C index of about 0.6. So it's very close to tossing a coin, but it's been validated in multiple databases. So, and it's so simple to use that has been embraced by the clinical community. Here in the GRACE risk model, we have the Achilles class, that I hope that the residents know what that is. If they don't know, just make sure they learn, because I will ask about that in rounds. The systolic blood pressure, the heart rate, the age, the creatinine level, and then other risk factors like cardiac arrest that I've mentioned, ST deviation, or cardiac marker elevation. So that goes into a specific formula, and you add with the points, and then the residents don't have to learn this by heart, and then they can estimate the risk of the patient. When the risk score is more than 140, that's classified as high risk. When the risk score is less than 110, it's classified as low risk. And that can easily be calculated without having to memorize all that stuff using the GRACE webpage. I think they also have an app. Here you can see the reference line is the webpage. You can easily calculate the GRACE risk score. So in terms of management of ACS patients, let's talk about general measures first, because this is something we do and we never think about. Guidelines recommendation. So nitrate. We love, and so we all have nitrate. So the recommendation is class C, so level of evidence expert opinion. So in patients with non-ST-ACS, with non-ST-ACS, they could be given sublingual nitro every 5 minutes of roughly 3 doses, and then decide whether or not they took the risk of intravenous nitrogen. IV and nitrogen is for patients for patients with non-ST-ACS, for ischemia, heart failure, hypertension. And then, can you all hear me?
Mauricio, your microphone is sort of deteriorating. I don't know.
Hang on one second. Let me just make it. Can you hear me a little bit better there?
That is much better, whatever you did.
Okay, hang on one second because I'm having problems with the monitors now. The monitors have disappeared. Give me 1 second. Okay, 1 second. Give me 1 second. I'm having some technical issues. Um, I don't know how to share my screen. Hang on 1 second now.
At the bottom of the, there's a
See that?
whole list of icons, participants, chat, share screen.
Yeah, no, I see that, but I can't just. Okay, I found it. Okay, perfect. Share screen. Okay, so. Okay. Okay, you can, I guess you can see my screen now.
Yes,
Okay, perfect. Everything okay now?
much better.
Okay, perfect. So we're talking about, okay, we're talking about, okay, we're back. Okay, so we're talking about nitrates. So IV nitro is indicated for patients with non-STACs for terms of persistent ischemia. Nitrates should not be given in patients who had phosphodiesterase inhibitors like sildenafil or tadalafil. So analgesic therapy, we usually like to calm and to relieve the pain of the patients that come to the ER, but sometimes the pain is not severe, and also I use the pain to actually monitor my reperfusion therapy and whether or not the patients reperfuse spontaneously. So in the absence of contraindications, it may be reasonable to give morphine to patients with non-STACs with continued chest pain by treatment. And then NSAIDs for aspirin should not be used because it increases the risk of MACE. It's interesting that opiates also slows the intestinal transit. So there's been a black box warning for the P2Y12 receptor blockers that the co-administration with opioid agonists delay or reduce absorption of ticagrelor, for example, and its active metabolite, presumably due to slowed gastric emptying. And then there should be consideration for other parenteral antiplatelet agents in those situations. Use of beta blockers. This is important because I've seen beta blockers given IV in the ER in patients who are allergic shock, and those patients can be tipped over towards shock. Hang on 1 second. Okay. Is everything okay, Jeff, now with the video and everything? Okay. So oral beta blockers should be in patients who do not have any of the following: signs of heart failure, evidence of low output state, increased risk for cardiogenic shocks, or any other contraindications to beta blockade. For example, a PR interval of more than 0.24, or any type of AB block, active asthma, or reactive airway disease. In patients with stabilized yes, and stabilized heart failure and reduced systolic function, beta blockers are indicated, especially the ones that have proven to reduce mortality in patients with heart failure, like long-acting metoprolol, carvedilol, or bisoprolol. Then we continue with beta blockers in patients with contraindications for beta blockers during the first 24 hours. Maybe the patient should be reevaluated for a subsequent eligibility. It's okay to continue beta blockers in patients with normal LV function and non-STSCS, and then IV beta blockers is potentially harmful, and especially in patients with risk factors for shock, and should not be given. Another agent, especially for hypertensive patients that come in the ER, is that we don't want to give nifedipine in patients that are not taking beta blockers previously, and that's a class 3 indication because it's harm and can cause increased mortality.
Another important aspect of the care of patients with non-ST-ACS is the assessment of a lipid panel, and that is also a benchmark of care according to the NCDR. So our processes of care are evaluated according to our assessment of a lipid profile in patients with acute coronary syndromes. And then we are also evaluated in terms of quality about the initiation of statins in patients with ACS. So it's very important because the quality department is going to be chasing you if you don't take charge of lipid agents. There's also data that demonstrates that statins are beneficial. Acute use of statins in the setting of acute coronary syndromes is actually useful. So let's move into what's next after we assess the patient in the ER. We decided whether or not we're going to give beta blockers, nitrates, painkillers. So the question is to cath or not to cath. But the question, is this still the question? Maybe it's no longer the question, because I think that the answer is that you shall cath all patients with non-ST-ACS. The questions are now when, as soon as possible, or you stabilize first, on how to treat. You just treat the culprit or just do multivessel PCI. So, invasive coronary angiography is important. Invasive coronary angiography is important because it allows you to confirm the diagnosis of acute coronary syndrome related to obstructive epicardial CAD, and also allow us to triage very quickly the patients that have non-obstructive CAD, and also identify patients with SCAD that have a different treatment. It also got treatments and avoid unnecessary exposure to antithrombotic agents that can make patients bleed, and bleeding is a bad outcome and is associated with poor prognosis, and allows us to identify culprit lesions as luminal defects, plaque ulceration, irregularity or impaired flow, and allow us to tailor treatments and decide on more aggressive antithrombotic therapies. And then we can also define our indication to revasc and use PCR CABG based on the anatomy and stratify patients short and long-term risk. So the first question about to cath or not to cath, I think that's not a question anymore, because this meta-analysis of 3 important randomized trials, phase 2, RITA-3, and ICTUS, that involve more than 5,400 patients, you can see that there's benefit for high-risk patients, for intermediate patients, and low. The absolute difference between the invasive and the conservative management is higher in the high-risk patients, but the magnitude of the benefit is about the same. And the P for interaction is there's no interaction between treatments. So all patients across the board benefit, regardless of the risk. Obviously, you get more bang for the buck when you are dealing with high-risk patients, because those are the ones that are going to, in absolute terms, are the ones that are going to benefit the greatest. In terms of when you want to cath somebody, so there's this important study. This is called TIMAX trial that was published now more than 10 years ago. And they looked at the overall trial, showed no difference. They defined routine early intervention as 24 hours or less, and delayed intervention of 36 hours or more. They enrolled more than 3,000 patients, and they found out that patients that are at high risk may benefit from early intervention, but those with low to moderate to intermediate risk may not benefit from early intervention. And here you can see that when they estimated, when they looked at the different subgroups, the subgroup that has the higher GRACE score, the ones that are at high risk, those ones clearly benefit from early intervention with a significant p-value for interaction. A subsequent meta-analysis published in Lancet by Jobs is interesting and shows about 8 trials. And it shows heterogeneity on the design of the different trials. In red, you can see the time at which patients were cathed in the early invasive strategies, and here in blue you see the time when cath occurred in the delayed strategy. And then when they looked at all-cause mortality, the difference overall was not statistically significant, although there was a trend towards benefit with the early invasive strategy. Then they had, because this is an individual patient and meta-analysis with individual patient data, they looked at high-risk subgroups, such as patients with elevated cardiac biomarkers, and then you can see that there's a significant interaction, and patients actually benefit with a reduction a relative reduction of 24%. And then in patients with elevated grace risk score, they also benefit with a relative reduction in events of about 30%. And the other high-risk subgroups that were defined were diabetics and older adults that also had a significant reduction in events with the early invasive strategies. So as a summary, you can say that the early invasive strategy is superior to the standard care in defined subgroups, such as patients with elevated cardiac biomarkers, high grace risk score, older adults, and diabetic patients. This study was published after that meta-analysis a couple of years ago. This is a study done in Denmark that also looked at patients with a non-ST-ACS. And the primary endpoint was all-cause death, non-fatal recurrent myocardial infarction, hospitalization for heart failure, hospitalization for refractory myocardial ischemia. They were randomized to very early invasive, and then the angiography occurred at 4.6 hours versus standard invasive, and the angiography occurred almost 3 days later. This is a large study with about 2,000 plus patients, and then the overall study showed no significant difference between the very early invasive and the standard treatment. But then when they looked at the subgroups, the subgroup with a grade score of more than 140 actually did benefit from therapy with a P for interaction of about 0.023. What happens in practice is interesting because over time, treatment have shortened, and I think the cath labs are more available. And for example, in 2013, the Champion Phoenix, the median time to cath was about 5 hours, very similar to the treatment time used with a very early invasive therapy in the Verdict trial that I just showed you in the slide. Then the other question was, do we do single stage versus multi-stage PCI? That means single stage means that you do all the vessels in one time versus multi-stage that you do the vessels in staged interventions. So there's been a number of meta-analyses and only one randomized clinical trial, the SMILE trial done in Italy. And they enrolled 584 patients, randomized 1-to-1 to single stage versus multi-stage PCI. They looked at the primary endpoint that was major adverse cardiac and cerebrovascular events at 1 year. And they did exclude patients with cardiogenic shock, CTO, syntax score more than 32, previous CABG or candidate for CABG. So this was a selected publication. And you can see that there was a significant benefit for the multi-vessel PCI versus a staged PCI. And then that difference was about almost 10% absolute reduction in the primary endpoint. So it's important that we re-stratify these patients, and I can tell you that we have very high risk, intermediate risk, and low risk. The very high risk have all been excluded from all these randomized clinical trials because the general consensus is that those patients should be cath within 2 hours. Those are the patients with hemodynamic instability, refractory angina, life-threatening arrhythmias, acute heart failure, or dynamic ST changes. So those patients, you see them in the ER, you just want to cath them as soon as possible because those patients may be unforgiving and may have further complications. In patients with high-risk criteria, those can be stabilized, and those are the ones with a grade score of more than 140, the ones with intermediate risk, the diabetic patients, the ones with CKD, low ejection fraction, prior revascularization procedures, and then finally we have the low risk without any of the characteristics mentioned. So this is what the Europeans recommend in their guidelines. So very high-risk patients, early invasive therapy within 2 hours, high risk, early invasive within 24 hours, intermediate invasive within 72 hours. And then in the low risk, you can opt, depending on the expertise of your site, between invasive without any emergency versus non-invasive testing if considered appropriate. So our guidelines say the same, basically more or less the same thing, so that an urgent immediate invasive strategy is indicated for the very high-risk patients with refractory angina, hemodynamic or electrical instability. An early invasive, that means within 24 hours, is recommended for patients that are high risk. In patients with who are initially stabilized or who are at intermediate risk, a delayed invasive approach is reasonable to do. And then an ischemia-guided strategy or a conservative strategy with a class 2B may be also indicated for patients who are completely stabilized. And then the guidelines also say that the preference of clinicians and patients should be considered in the decisions. And those are class 2B indications. But in general, in our hospital, we practice an early invasive strategy. The cath lab is always open. And I think patients benefit from that all across the board. There's no benefit for an early invasive strategy when there are significant comorbidities in whom the risk of revascularization and comorbid conditions are likely to outweigh the benefits of revascularization. We're faced with those decisions, especially more recently when we have very sick patients in the ICUs. And then obviously patients with low likelihood of ACS who are troponin negative may not benefit from an early invasive strategy. So additional factors to consider. So individual bleeding risk, antithrombotic management, and access size. So there's been advances over the past decades on antithrombotic therapies. There's been an increased use of more potent ADP antagonists, P2Y12 receptor blockers that have a more rapid onset than clopidogrel. There's been a marked decrease in the use of GPIs because they're associated with significant bleeding, especially with upstream P2Y12 inhibition. GPIs seem to be left to the discretion of interventionalists in the cath lab. The development of second and third generation DES are less thrombogenic than first generation DES, and they are safer. I can't remember when was the last time I actually placed a bare metal stent, even in patients that require surgery. And I still recommend the drug-eluting stents of the latest generation. And there's also been an increased use of transradial PCI. Now, this is an old number. The most recent number is that about 50% of PCIs in the US receive transradial access. So that's a significant increase. In 2007, we were around 1.5%. In 2012, we were around 16%, and now we're at 50%. So I think that with the younger interventionalists that are trained in this access modality, I think that there's radial access has tipped over in the United States. And the guidelines in Europe, in the other side of the pond, recommend that in centers experienced with radial access, the radial approach is recommended for coronary angiography and PCI with a class 1 recommendation and level of evidence A. So, and they also recommend that centers treating ACS patients implement the transition from femoral to transradial access, and proficiency in femoral access should be maintained for mechanical circulatory support devices, structural and peripheral procedures. And then in addition to that, I can say that that interventionalists should become facile with the use of ultrasound to guide access, because it is safer. The data supporting the use of transradial access in ACS comes from the Matrix trial, which enrolled more than 8,000 patients, and they did a 2x2 factorial design testing bivalirudin versus fractionated heparin and transradial versus transfemoral access. These are the results of the access part of the study that show the significant reduction in the composite of death, MI, and stroke, and also a significant reduction in the composite, the primary endpoint of death, MI, or stroke, and major bleeding, BARC 3 or 5. So this is important and should be implemented. And then with a group of interventionalists across the country, we wrote this scientific statement on transradial access and best practices for coronary angiography and intervention in ACS, and we recommended that a radial first approach should be strongly considered in all patients, but the operator should be experienced. And a number of other issues related to the practice of transradial access. But this was the first time that an American professional society recommended strongly the use of a radial first approach. In terms of antithrombin agents, there are 4 class 1 recommended agents. So those include enoxaparin, bivalirudin, fondaparinux, and intravenous fractionated heparin. The guidelines say that in all patients with non-ST-ACS, anticoagulation in addition to antiplatelet therapy should be given to all patients irrespective of initial management strategy. And that's a class 1A indication. So the best data actually is for enoxaparin that we rarely use because of the long half-life, the inability to use a point-of-care device to test the intensity of anticoagulation, and then it complicates the logistics in the cath lab, because I mean there's also about the issue of stacking doses. So clinical trials have shown that bleeding can be excessive with the use of enoxaparin. Bivalirudin is a drug that is a direct thrombin inhibitor, and it's been used very widely about a decade ago, and the use has declined significantly. Because glycoprotein 2B3A inhibitors have dropped in use, and that was a factor that was causing more bleeding in patients treated with heparin only. So bivalirudin is used less frequently now. It's associated with less bleeding, and also has good data supporting its use. Fondaparinux is a drug that I'm not sure that we have on formulary. It's been shown to be beneficial in patients with non-ST elevation acute coronary syndromes in the OASIS trials. However, this drug does not support PCI because clots in the catheters have been found. So, you know, it's just, I mentioned this because it's in the guidelines, and it's also because of historical importance. And the drug that we use in almost all cases is just a good fractionated heparin, which is not a perfect drug, but it works, and we give it for 48 hours or until PCI is performed. So Dr. Alfonso last week talked about antiplatelet agents in a very, very comprehensive lecture. Just want to emphasize a couple of topics about deferment of pretreatment. So I would like to say that CABG is still needed in about 7 to 13% of cases of non-ST elevation acute coronary syndromes. Not all surgeons are willing to treat patients on dual antiplatelet therapy. So because of the risk of bleeding, so patients may stay longer in the hospital. And remember, now in the midst of this COVID pandemic, keeping a patient in the hospital also increases the risk of exposure to COVID. And there's been horror stories in cases presented in different conferences about patients that got COVID or inadvertently were operated with them after being infected with COVID, and they had catastrophic outcomes. We want to avoid overtreatment of patients not found to have coronary artery disease. Now, early invasive therapy occurs within hours rather than days. In the CURE trial, I think that the mean time to PCR, to angiography was about 4 days. In the other trials was about 6 days in Europe. And now, as we saw more recently, it's just hours, 5 hours, 4 to 5 hours. The risk of ischemic complications before angiography is also low, and there's no compelling benefit associated with the early initiation of P2Y12 inhibitors before knowing the coronary anatomy. So this is an anecdotal picture showing an angiogram and the two tablets of clopidogrel in the stomach of the patient. So obviously there's no antiplatelet effect in this situation. And considerations for use of intravenous antiplatelets according to the ESC 2016 guidelines. So GPIs could be considered for bailout situations or thrombotic complications, and that's the way we use it. That's a class 2A indication. Cangalor may be considered in patients who are P2Y12 inhibitor naive undergoing PCI, and it's not recommended to administer GPIs in patients in whom coronary anatomy is not known. These are nice data about preloading in patients with non-STEMI and stable CAD. So the data comes from the CREDO, Prague 8, and ACOS trials. And it shows that in terms of efficacy, there is no difference between preloading and no preloading. But then the problem is that the safety is compromised, especially in the study Prague 8 that showed increasing bleeding events with preloading with clopidogrel. And then also in the ACOS trial, there was significantly increased bleeding events in patients that were pre-treated. So I don't think we should pre-treat patients until we see the coronary anatomy, especially because a not low % of patients may require surgery, and the risk of events is low, and the time to angiography is very short. I cannot emphasize that more. So when you're ready, you revascularize your patient, you're ready to discharge the patient. So you don't want to forget your ABCs: aspirin, beta blockers, cholesterol management, diet, education, antithrombotics, blood pressure control, smoking cessation, diabetes control, and exercise. So this is what all these regulators look at, and these are many of the quality indicators. So your hospital may get dinged if you actually are not following not implementing these management strategies for your patients. So important to remember that. So in terms of secondary prevention after non-ST ACS, so class 1, cardiac rehab. I know Sabine is there, and the group from cardiac rehab always follow very loyal our grand rounds. Kudos to them. I am very, very happy when my patients are able to enroll in cardiac rehab, because it's like following my patients by remote control. I always get a call from Jessica or Sabine or somebody else from the group, or Mariel, about my patients, and my patients are happy as they can be when they come back, because they feel they can reinsert in society much better after they have an adverse event, such as an acute coronary syndrome. So pneumococcal vaccine, education about lifestyle modifications. So class 3, no benefit, antioxidants, vitamins, folic acid, and class 3 harm, hormone replacement therapy, and COX-2 inhibitors. So in summary, I would say that the foundation of ACS management is antiplatelet therapy, antithrombin therapy, and invasive risk stratification for high-risk patients. Radial approach is preferred in ACS patients undergoing invasive risk stratification and PCI. And always remember prevention measures to reduce long-term risk, because over time, these are the patients that continue to experience events because of their multiple cardiovascular risk factors and the high burden of cardiovascular disease. And here I would like to finish and open the forum for questions. Thank you so much.
Thank you, Mauricio. That was really a great overview. The one question I would have for you is, with all the interventions that that we now have, we still have sort of a plateauing of outcomes with STEMI. Do you think we've achieved the best that we can, or are there, looking into the future, what do you see as possibilities to get even better?
Well, it's hard to say. So, there's still residual risk after you implement all these treatments, right, Jeff? So I think that there's always opportunities. So we are, I think that we understand the efficacy of the drugs, but we also understand the safety and harm that we can cause. So by being more careful, by being more judicious, and at the same time being aggressive enough, is a way to treat. So usually first do no harm. In addition to that, there's still other platelet receptors that can be inhibited. There are other factors in the coagulation cascade that can be also inhibited. But clinical trials are very difficult to perform, because all you have to add on to treatments that are already established. For example, there was an agent, Vorapaxar, that was developed to inhibit the thrombin receptor in the platelet, and we know that thrombin is the most potent platelet stimulant of platelet aggregation. But then that failed in large clinical trials with investments of millions and millions of dollars because there was excessive bleeding. So I think that the field will continue to evolve. We need to recognize outcomes, and hopefully, I'm not entirely sure. Maybe studying individualized therapies, stem cell research.
Dr. Cohen is Azar. Sorry, I have a question. It was a great presentation, by the way. Why we shouldn't give nifedipine in a setting of acute coronary syndrome? I couldn't get the reason.
Nifedipine is a class 3 indication because it actually increases heart rate in patients who are not beta blocked, and I think increases sympathetic reflexes. So it's been shown in clinical trials. So we don't give nifedipine to patients that present with acute coronary syndromes.
Mauricio,
Thank you, Doctor.
Yes, Mary.
what are your thoughts on the newer diabetes drug for secondary prevention, at least in diabetics?
I think that's very interesting. So I'm gonna give an ad. Jeff is conducting a very important study called the LEAF trial, looking at the GLP-1 inhibitors. That's a glucagon peptide, and those modulate atherosclerosis. So I think it's very interesting, and more I see that more endocrinologists are using these drugs more often. And then you have the other agents like I can't remember the
Sodium glucose.
SGLT2.
yeah, like Farxiga.
Yeah.
I don't want to give an ad to AstraZeneca, but those agents actually modulate, decrease the absorption of glucose in the tubule, and then causes diuresis, so decreases the loading conditions in patients with heart failure and actually improve outcomes. So I think that those are for secondary preventions. I mostly concentrated in the acute phase, and I try to go through the pathway of care of these patients. So they can use this lecture as a template on how to manage patients in the acute setting and the hospital admission, and don't get dinged by the regulators who are always looking at the rates of PCI, the rates of complications, and the use of evidence-based medicines. Any word about the LEAF trial, Jeff?
We are enrolling. We had a brief period of inactivity due to COVID, but we're back up and running, and we've had several enrollments. We've had very good participation from patients. Early results look extremely positive. It is an open label trial, so, yeah, we're very pleased with the progress. So once again,
Mauricio, question. You have a patient who comes in on late Friday or Saturday and has a troponin leak. It's been stabilized, no more pain. What is your approach?
Okay, so that study was actually done from the Crusade database, looking at patients that came, exactly the same questions as you, patients that came before the weekend and had a longer time to cath versus the patients that came during the week that had a shorter time. There were no differences. So if you look at the data in aggregate, including all patients, there's no benefit from the early invasive approach. That was kind of a relief to all interventionalists when they attended the TIMAX trial presentation a few years ago. So, and then the indications for early angiography are not a class 1 indication, it's a class 2A, class 2B indication. So you can actually stabilize the patients, and if they have recurrent pain, if they destabilize, you can bring them back to the cath lab. Obviously, if the patient comes with very high risk features, with electrical instability, dynamic EKG changes, refractory pain, those are patients you have to take to the cath lab much sooner.
Dr. Cohen, this is Walid. I do have a question. Thank you for the nice presentation. Oftentimes we see patients with non-STEMI, and we do the risk stratification by both STEMI score and GRACE. And the TIMI score will be a high, like a 6 or 7, and GRACE score doesn't correlate with the patient at the lower risk. What do you think about that?
So the question is about discrepancies between
yes, but TIMI score and GRACE score.
So remember, I don't know if that has been studied. I haven't looked at the study. Looking at that, maybe you should do a bibliographic search, and then if there's nothing studied, maybe you should you should look into that. I think that you have to use your best clinical judgment and determine your gestalt about the patient. So, but if the patient is diabetic, if the patient has positive cardiac markers, the data is sufficiently evident to do an early invasive. But remember, all the patients benefit from early invasive strategy. And if your hospital is experiencing using, not early, but an invasive strategy, your hospital is experienced and you have a good interventional team, there's no reason to defer patients. And then also remember that an invasive strategy streamlines care, so you can safely discharge patients patients.
All right, we're getting a lot of interference here, so if you're not talking, please mute. Mauricio, we have one last question from Steve Borzak.
Okay.
Thanks, Jeff. Beautiful talk, Mauricio, and it really shows all that goes into making the guidelines. Your grasp of the literature is really phenomenal. You led off with the distinction between myocardial injury and acute coronary syndrome. And I find that this is one of the biggest problems that we encounter regularly in the hospital, that myocardial injury is treated as ACS, and we're not really making that distinction adequately. Is there anything else that you could underscore for our trainees, especially in July, that would help us understand and recognize the important difference between these two conditions?
Well, I think that when looking at myocardial injury, you have to follow the pattern. You have to follow all the other comorbid conditions that could that go into the differential diagnosis of for cardiac marker elevations, like patients with PE, now patients with COVID. The STEMI likes are very puzzling, caused by COVID. The patients with sepsis, patients with kidney failure. And again, you have to rely. The new trainees don't have that much of a clinical judgment, but they have to seek the help of senior fellows or their attendings to tease out which are the ones that have myocardial injury and the ones that have myocardial infarction. But looking at the pattern, I think that looking at the pattern of rise and decrease of cardiac markers is probably the most important thing, in addition to a good thorough examination and history taking at the bedside to understand all the other comorbid conditions that cause that goes into the differential diagnosis. I don't know if I answered the question. So why don't you tell me, Steve? You are a very experienced clinician and you know the data very well.
Means a lot of gray hair. I agree with you completely that it really comes back to the clinical diagnosis. And troponin is not synonymous with acute coronary syndrome. It is synonymous with injury, but we have to put the diagnosis on first and then look at the study second.
Okay, well, thank you, everyone. Have a great day, great week, and we'll see you next Wednesday. Please stay safe.
Thank you so much, Jeff. Thanks, everybody, for listening.
Thank you, Mauricio.
Take care. Bye-bye. Betty.
Hi. Good job.